Hello, everyone, and welcome to our video brunch. We're going to talk about new therapies and new approaches to treatment in IBD. I'm Dr. Aline Charabaty, founder of Monday Night IBD and Associate Professor of Medicine at Johns Hopkins School of Medicine and the Clinical Director of the IBD Center at Hopkins Sibley Memorial Hospital in Washington, D.C. I'm joined today by my colleague and very good friend, Dr. Bruce Sands. Dr. Sands is the Dr. Beryl Crone Professor of Medicine at the Icahn School of Medicine at Mount Sinai and the System Chief of the Division of Gastroenterology at Mount Sinai Health System in New York. Bruce, welcome and thank you for joining me.
Thanks for having me, Aline. Nice to see you.
Our video brunch series is CME certified and jointly provided by Global Education Group and Bonum CE. These activities are supported by education grants from Janssen, AbbVie, and Takeda. Our disclosures are shown on screen. If you haven't already completed our pre-activity survey, please do so by clicking the link below this video or by scanning the QR code shown here. Let us know who you are in the polling questions below. And please make sure to complete your evaluation at the end of the session so you can claim your CME credits. And of course, follow Monday Night IBD and Bonum CE and set your notification so you can be aware of new CME certified programs. Upon completion of this educational activity, participants should be able to evaluate the clinical efficacy of new therapies, emerging therapies, and combination therapies in the space of inflammatory bowel disease. Bruce, so before we jump into what is new in the field of IBD in terms of new mechanism of action, new classes of therapy in the pipeline, let's review together what does it mean to treat to target in IBD, what are our current targets, and what are we hoping for new therapies coming in the pipeline? What different targets are we hoping to achieve when we're talking about remission in IBD?
Yeah, it's a really good question. We've all heard of the STRIDE guidelines that came out of IOIBD and the revision of the STRIDE guidelines with STRIDE 2. And really, this introduced a treat to target approach to be applied to patients with inflammatory bowel disease. I would add that this is not something that is intended for research, but it is really for the practitioner of IBD to try to get patients to achieve what they need to get to feel well and stay well over the course of their disease. So, of course, we're interested in how the patient feels, and that's reflected in patient-reported outcomes like stool frequency, rectal bleeding, abdominal pain, and Crohn's disease. Those are always important. But we've learned over time that unless you achieve objective findings and reach those goals, you don't actually sustain those patient-reported outcomes for very long. So what STRIDE 2 did is it outlined the sequence by which you expect these targets to be hit. So it starts with improvement in patient-reported outcomes, but then progresses to also include objective things like biomarkers, such as fecal calprotectin or C-reactive protein, whichever is elevated for your patient. Then we want to see resolution of the symptoms, and ultimately we want to see healing of the mucosa, whether that's documented by colonoscopy or in some patients with Crohn's disease, it might include cross-sectional imaging. And these occur over time, but eventually it's an iterative process and you want to get all patients to those ultimate targets as best you can, even if you have to adjust therapy, change dosing, or even switch therapy altogether. And the last thing to comment on is there are some goals which were omitted potentially from the STRIDE guidelines. For example, STRIDE 1 and STRIDE 2, neither of them include histologic improvement or histologic healing for ulcerative colitis. Now, since the dawn of clinical trials, the very first randomized controlled trial with corticosteroids in ulcerative colitis, actually Truelove and Witt included histology. So they knew decades ago how important histology was. And I think we know that too, because it's the microscopic disappearance of neutrophils and healing of the mucosa at that very basic level. So I think we can expect to see that included in STRIDE 3 when that eventually comes out. And for Crohn's disease, transmural healing was not included, but I think there's more and more evidence to suggest that we need to reach for that as well. We know that patients who do achieve histologic healing do have better outcomes. But it's one thing to say that the patients who achieve histologic healing do better, And it's quite another thing to say, if we push a patient through more intensive therapy to reach that target, if they haven't already achieved it, do we get incremental benefit? To do that, to understand if that's important, you really have to do a randomized controlled trial. So there is a trial that's almost done being conducted now called the Verdict study, which is really designed to determine the optimal treatment target in ulcerative colitis. And basically, it's randomizing patients with ulcerative colitis to either treat to symptoms, which I think is probably not the best thing anymore, or to treat to symptoms plus endoscopic healing or improvement. And the third group is randomized to treat all the way to histologic improvement or resolution of histologic activity. So patients who don't achieve these at various time points along the way have escalation of their therapy. And at the end of 96 weeks is the primary outcome, which is going to be the difference in time from target achievement to UC-related complication, comparing groups 1 and 3. Group 1 being treat to symptoms, group 3 being symptoms plus endoscopy plus histology. Once we have these data, I think this could be a very important piece that pushes the field forward and really compels us to treat patients to histologic healing.
So I want to start talking about the new classes of drug that are currently being evaluated in IBD. So let's start with TNF-like ligand 1A inhibitors, or TL1A. So my understanding, Bruce, is that this is a protein that plays a key role in the inflammation and in fibrosis. So potentially we have a new MOA where we can both treat the inflammation, prevent the fibrosis. So that's very exciting. Can you tell us more about the current 3 different TL1A inhibitor being studied?
Yes, absolutely. It's worth commenting on what TL1A is and what it does immunologically. So it is a cytokine, a member of the tumor necrosis factor superfamily of cytokines, but it is very different from TNF. It activates innate immune responses as well as adaptive immune pathways, and it does this by binding to death receptor 3, also called DR3. And the pro-inflammatory effects include T cell activation, but very importantly, and perhaps very significant for therapeutics, TL1A also enhances fibrosis, again, through the binding with DR3 receptor. So with one agent, you might be able to inhibit inflammation, inhibit the immune response. That clearly is very important and central to inflammatory bowel disease, both Crohn's disease and ulcerative colitis. And you might be able to prevent or potentially even reverse fibrosis. So if we're thinking about fibrosis in our patients with Crohn's disease, this could be a stricture. In our patients with ulcerative colitis, this could be the chronic inflammation and consequential fibrosis of the submucosa that leads to loss of function over time. So we have 3 TL1A inhibitors where we have phase 2 data. The first is tulisokibart, previously called PRA023. We have a second called afimkibart, previously called RVT3101. And the third is called duvakitug, which previously was called TEV48574. The names are not much easier than the numbers, but they're a little bit easier. And we'll start with duvakitug. This is really interesting because it's a rare example of what we call a basket trial. Basket trials where you have multiple disease conditions studied in the same study with the same agent. And so here we have patients with both UC and Crohn's disease in the same study, although analyzed separately, as you'll see. We had equal randomization in each group. For the Crohn's disease cohort, there were 40 assigned to a higher dose of duvakitug, 900 milligrams sub-Q every 2 weeks. There was a lower dose of 450 milligrams sub-Q every 2 weeks, and then matching placebo sub-Q every 2 weeks. And then the primary endpoint was achieved at week 14, and this was defined as endoscopic response, meaning a decrease by 50% or more from the baseline simple endoscopic Crohn's disease index. And so this is in some ways a very innovative design and very conventional kind of moderate to severely active Crohn's population, just like you would see in any other study. But a lot of these patients also had prior failure of lots of other therapies. First, we'll see the duvakitug Crohn's results. And on the left-hand side, we're looking at the primary endpoint, which was a decrease by 50% or more from baseline SES-CD at week 14. And you can see that placebo, this was achieved in only 13%. At the lower dose, 26% achieved this, and at the higher dose, 48%. So clearly some sort of dose response here, and the higher dose performing exceptionally well in comparison to placebo. And interestingly, of course, as you would expect, the patients who are at the lower end of SES-CD baseline scores, they perform a bit better than the ones who are higher than 15 for their baseline SES-CD. But still, even with that higher SES-CD group, you see very significant differences here. Looking at the endoscopic remission rates at week 14. Now imagine that that's essentially healing the mucosa. Maybe there are a few aphthous ulcers. And there you see a treatment effect size overall 17% superior to placebo. So overall, a quarter of patients roughly achieve that. Once again, you see this happening more often in the patients who had a baseline SES-CD of 15 or lower, but still you see a higher proportion of patients, even with the higher baseline SES-CD score, achieving this very stringent outcome. And then clinical remission, of course, we want the patients to feel better. Here you saw, as sometimes happens, a relatively high placebo clinical remission rate of 26%, but still there is a difference of about 11% overall for each of the two different doses. And again, the patients who had the lower SES-CD scores at baseline, they did a little bit better, but here you saw an even higher placebo response rate, whereas with the SES-CD scores of greater than 15, you have a placebo clinical remission rate of only 8% compared to 27% for each of the two different doses of duvakitug. Moving on to the second of these agents, we have tulisokibart, and this was reported out in the Artemis UC study published within the last year in the New England Journal. And this was an interesting study because there were two cohorts, also a phase 2 study. Patients were randomized to drug or placebo, 60 in each group in the first cohort. And in the second cohort, there were additional patients who had positivity for a putative biomarker to predict response to anti-TL1A treatment. So cohort 1 included patients who were positive or negative for that biomarker predicting response. Cohort 2 focused on the patients who were strictly positive for the biomarker. And it was a conventionally designed study otherwise, but this predictive biomarker approach is really quite interesting because it may be one of the ways in which in the future we can improve response and remission rates to our drugs. So here you can see the primary outcome was easily met with an advantage over placebo of 25%, a very important effect size, reminiscent of what we see with upadacitinib. And for endoscopic improvement, you see about a third of patients achieving that on drug, and 2/3 of patients are achieving clinical response. And I don't think I'm showing you any of the safety data, but at least in this short-term study for both duvakitug and for tulisokibart, the safety profile seems quite good. And in fact, we don't see immune suppression signals like we do with TNF. We don't see infections emerging. So that's a very hopeful sign. Some other endpoints with tulisokibart include symptomatic remission, histologic improvement, histoendoscopic improvement, the combination of histologic improvement and endoscopic improvement in the same patient, mucosal healing, and also IBD-Q response. So all these things were highly significantly positive in that cohort 1. We also have some data in Crohn's disease for tulisokibart. This was recently published in Lancet Gastroenterology and Hepatology. It's the Apollo CD study. Again, a different study design because it's a single arm. It's not blinded. Everyone's getting the drug, but we have comparison through a Bayesian analysis to expected outcomes. There's also an open label extension and maintenance treatment phase of the study, which will be reported at some point. With regard to endoscopic response at week 12, it was 26% of patients achieving that endoscopic response to tulisokibart with Crohn's disease. And at week 50, the higher maintenance dose of 250 milligrams sub-Q seemed to perform better than the lower dose of 100 milligrams. And that was 28% with the higher dose versus 16% for the lower dose. So it seems like the higher dose is more effective for maintenance. And for clinical remission, it's sort of the same message.
This is fascinating. Very excited about these new MOAs and it seems that similar to anti-TNF, maybe the TL1A have some kind of dose response relationship and very effective and no new safety signal. So very encouraging. Bruce, maybe you can guide us through another MOA that's been evaluated in IBD, the microRNA 124 enhancers. Again, my understanding is that this microRNA has anti-inflammatory property. So when it gets upregulated, it can reduce the inflammation in the GI tract. And like you said, they do not make those names easy on us. So
No, they do not.
again, they're all tongue twisters. So obefazimod, also known as ABX464, is being evaluated in UC. Can you walk us through the data that we have so far?
Yeah, sure. Obefazimod, it's a small molecule. It is not itself a microRNA. It's not an RNA at all. It's a chemical compound. But what it does is it binds to the cap binding complex in the nucleus of various immune cells of different sorts, and it selectively enhances the expression of one species of microRNA. And if you remember, the Nobel Prize was awarded within the last year to the discoverers of microRNA. But this microRNA species 124, when it's enhanced, it downregulates inflammation. So it reduces the translation of messenger RNA targets and then stabilizes levels of cytokines in such a way that it doesn't suppress them, it just sort of normalizes them. And so you wouldn't really expect to see immune suppressive signals. And in fact, in the safety data, we don't see signals of infection and various other concerning things that we see, for example, with anti-TNFs. So this has been studied in both a phase 2A and a phase 2B in ulcerative colitis. And both studies replicate each other. They clearly show the efficacy of this new class of medications. And here the outcome is change from baseline in the modified Mayo score. It's not conventional for what you would see in a phase 3 study, which is usually going to be clinical remission in ulcerative colitis. But you can see this is a very good effect size, regardless of whether you're looking at the lowest dose of 25 milligrams or the middle dose of 50 milligrams once daily or 100 milligrams once daily. And this is followed out to week 8. Same thing was seen in the phase 2A, and very good safety profile. The only thing that we do see for some patients is mild to moderate headache. It's usually short in duration. It's actually quite unusual for patients to have to stop the treatment because of the headache, but no other concerning side effects really are noted. The other notable point about obefazimod is the remarkable maintenance efficacy. Because there was long-term safety data, there were patients followed out to week 48 and week 96, and you can see on this slide that there is really remarkable durability of clinical remission, clinical response, endoscopic improvement, really little drop-off over time. And many of these patients also had failed other therapies. So I think this is a very promising agent. And in fact, literally just a day or two before we're recording this, there was a press release for the phase 3 results with obefazimod in UC, and they were really quite positive.
Bruce, thank you so much for walking us through the new classes that are currently being evaluated for the treatment of inflammatory bowel disease. We talked about TL1A inhibitors. We have 3 drugs being currently under investigation. And the exciting part of TL1A inhibitors is that they have the potential to not only be anti-inflammatory, but also anti-fibrotic. So this could have a really interesting implication for both Crohn's disease and UC. And then we also talked about microRNA 124 or obefazimod as a potential therapy for UC. So all exciting new classes with a good efficacy and good safety profile. So really looking forward to see what is next in the field of IBD. Thank you everyone for joining us today. Please make sure to claim your CME credit by completing the POS survey and the evaluation in the links below or by following the QR code shown on the screen.